Good morning. It's my pleasure, and thank you for the opportunity to share with you my passion about this project, which is about preventing or trying to prevent heart attacks. Now, the event is depicted here by the artist, Dr. Frank Netter, and this gentleman enjoyed a nice dinner, perhaps had a little bit too much wine. In any case, coming out of the place, walking a few stairs, he gets crushing chest pain, and he's the victim of a sudden, totally unexpected heart attack, like they are most of the time. And this is actually due to a rupture, an explosion of a plaque, hardening of the vessel, one of the vessels that is perfusing the heart. So, crushing pain in the chest. This indicates that there is insufficient blood supply and oxygen supply to part of the heart, because the artery that is serving that part of the heart is blocked. And the blockage happens when all of a sudden there is a rupture, a fracture at the surface. The white circle there is what's left for blood to flow through. And if you close that tiny channel, then you block the vessel completely, and this can happen by rupture of the thin cap that you see here. Because then all the material that is in the vessel and doesn't belong there all of a sudden will get in contact with blood, flowing blood. A clot will occur, and that clot will block the vessel. Now, if the patient is lucky, then he will be brought immediately to the hospital. Very quickly we can access the vessels that are perfusing the heart with this tiny little catheter that you see there. We inject dye, and you can see immediately at the top of the screen that the vessel is blocked. There is no dye that goes through it. So this patient is lucky because he did reach the hospital. We were able to reopen that vessel very quickly, get rid of the clot, place a stent, and in this way, if you're quick enough, you can actually salvage part of the heart that depends from that vessel, which will be very beneficial. Unfortunately, many patients are not that lucky. They may not reach the hospital. When the heart attack occurs, very often it comes along with acute rhythm disturbances. The heart goes fibrillating, and if the patient cannot be resuscitated, he may pass away on site. So this disease that is ubiquitous, hardening and thickening of the walls of our vessels, particularly the vessels of the heart, but also the vessels in the brain, it's a funny disease in a way because it has a stable course by which plaque is accumulating in the vessel wall over time. And that's what's shown here with the slope that goes up all the time. There is more and more plaque accumulation. But that doesn't really kill you. What may kill you is when you have an acute event, when something happens to that plaque, when it ruptures and blocks the artery completely. Now, trying to prevent plaque accumulation is exactly what is done with prevention, lifestyle changes, medication, and we'll hear a lot about that and the wonderful job that is being done by CRE. And then at the other end of the spectrum, we have the patients who come in with an acute heart attack. What happens in the middle? Nothing. Because we don't understand so far why a plaque suddenly will rupture. And that is an unmet need that is massive. So we're very good at preventing plaque accumulation. We're very good at treating the heart attack when it happens, but that's after the fact. Can't we do anything in between? The need is massive. These are some numbers about the number of acute events that still happen. In the US, they used to say there was one every 30 seconds, but that's unfortunately the case, and the same is true for stroke. If you look at Ireland, the mortality from cardiovascular diseases is pretty high. It's high both in women and in men, of course, higher in men. And the little numbers there, 13 and 33, refer to the ranking in the world regarding mortality, so it's actually pretty high for men in Ireland. And unfortunately, as I've mentioned to you already, we don't have much to offer. So the ambitious project that I'm really passionate about is to try to revisit this field and try to come up with some solutions to prevent heart attacks from happening. And the idea is that the time is right now to look at the three components of this paradigm. On one side, the vulnerable patient, the vulnerable plaque in the vessels, and the triggering factors. And I'll spend a few minutes explaining how these three interact. First of all, we can identify relatively well the vulnerable patient on the basis of risk factors, age, having hypertension, diabetes, being obese, having family history. These are clinical factors that identify within the global populations those who are at higher risk. But it is not enough. At the same time, we need to understand whether they have the substrate, because those who eventually get a heart attack are subjects who are the healthy carriers of plaque without knowing it. So what we can do now is identify those subjects, and this is done through imaging. We have a number of tools that can be used either when the patients are in the hospital, but also on an ambulatory basis, and therefore we can look at healthy subjects, and we can see whether there is plaque in the vessels through different imaging tools, and we can also identify the components of the plaque, and particularly if they contain high-risk features such as a lot of lipid, a lot of fat. And for instance, one example here, this is a normal subject, no complaints whatsoever, but clearly you can see at the arrowhead there that there is a narrowing that starts, and this image has been obtained on an ambulatory basis with a CT scan. So this takes 15 minutes, doesn't need a catheter procedure. So we have the means now to really identify whether there is calcification, the white dots, whether there is a narrowing, and we can also by detailed analysis find out whether this plaque has a high likelihood of rupturing if it is exposed to the stress, the right stress. And that's the next part in the paradigm here. First, we select high-risk patients, then you identify within that group higher risk subjects because they are the carriers of the substrate of the disease. You can image their arteries and find out that they have dangerous plaque. But then what was missing thus far is the analysis of the triggering factors. Why does this plaque suddenly rupture? This has been looked at from an epidemiological point of view in the past, decades ago, and a number of triggering factors have been identified, mostly related to stress, anger, having an argument, strong emotions, either good or negative emotions. And these are triggering factors that usually are present if you interrogate patients who come in with an acute heart attack. What happened last night? Well, had a big fight with my son, something like that. Very often there is a triggering that is related to emotions, but we don't understand or did not understand what was the relationship between this event in the brain, so to speak, and the rupture in the plaque in the coronary. And we have now the opportunity to look at this because we understand better that all these triggering factors probably act on the plaque through the effect of pressure or heart rate or their combination. So the blood pressure is the pressure P1 there, that is the blood in the vessel wall, and transmits inside the wall and also in the lumen of the vessel, and is of course affected by the presence of this abnormal structure there that is the plaque. So these pressure changes that occur when, for instance, you perform strenuous exercise, or when you have hypertension burst, or when you have acute stress, these pressure changes will exert a lot of strain on the plaque and may actually cause the rupture. And the same is true for heart rate. If you have excessive heart rate for a long period of time, the movement of the heart may also affect the stability of the plaque, and the combination of these two are factors that can cause the plaque to rupture, eventually leading to an acute event. Now, what is possible today is actually to analyze continuously with high granularity changes in heart rate and blood pressure through sensors, whether they're wearable or implanted. Once we have identified high-risk patients or subjects who happen to have high-risk plaque in their vessels, we can actually monitor those with high granularity and look at their changes in pressure and heart rate over time, and we can identify when they're reaching the threshold of risk for a plaque to rupture. So that is the overall paradigm and principle of the research that we're trying to implement here on this purpose. And by having these multimodality sensors, we can measure and monitor trigger activity and interfere with the risk when it is present. So in fact, the 3 steps are summarized here, and I'll finish here. Happy to take questions. First, we need to identify the right subjects at risk. Then we can monitor them, and once we have the signals, we can prevent the heart attack from happening by different ways, either by changing their medical therapy or by implanting devices in those plaques to stabilize them.
Would the patient receive a direct alert if through that monitoring they identify triggering factors, elevated blood pressure, elevated heart rate on a sustained basis, or risk of atrial fibrillation? Would the patient then directly receive an alert to go to the GP, or is the idea then the connection would be to the hospital, or how would the patient be alerted to identify?
So, in fact, first of all, there is 2 parts to your question. I'd like to clarify, maybe I didn't during the short presentation itself. There is a dual target. The whole low-hanging fruit, so to speak, are the patients, and you use the word patient. These are patients who have been sick already, are known to have the disease. For instance, if someone has a heart attack, we know that person is at higher risk for a second during the year to follow. So this is a time period during which the patients can be followed more intensely with these devices, for instance, in order to try to reduce the new event rate. Now, that is a patient, so that is a person who is medically involved, engaged, and I think it will be rather acceptable for those to be connected, yeah. And of course, they are in close contact with their GP and or the specialist, depending on their situation. So if we're dealing with a patient, I think it's easy to actually engage them and connect them also with their caregivers. Now, down the road, you really want to prevent the first event from happening, and therefore you have to deal with normal subjects, quote unquote, because they are the healthy carriers of the disease risk and the disease substrate. So this is a more difficult area, and of course it's an evolving one. We see that in a number of non-communicable diseases like diabetes, for instance, patients are very engaged with their own care, as you know. They have lots of information about the number of calories that they're eating, about their glucose levels. They make decisions about insulin that is being to be given, etc. So I think the same will happen in the cardiovascular era, and particularly with treatment of the risk factors. As I said, what is likely to make the plaque rupture is, for instance, a burst of hypertension. Now, you need to react to that if you see that the pressure is increasing over time. And yes, I suspect that patients will have to be taught how to deal with that. I mean, that's, I think, where medicine is going. The ownership of the data is moving from the doctor to the patient.
I wanted to ask, you mentioned implants directly into the plaque. How invasive is that, and at what stage are you at with that now?
You mean stents or sensors?
Sensors.
Oh, yeah. So what we're looking at really are triggers. So it's basically heart rate and blood pressure, plus a number of others that we may be looking at. So these can be collected from in different ways. Most difficult one is to have a wearable sensor for hypertension. I don't think that is a solved goal yet. We're still looking for that. But for instance, you can easily have the electrocardiogram and the heart rate with the electrical activity of the heart every minute for weeks. Data go to the web and you can watch them on a dashboard, no problem. So the invasiveness, I did not refer to sensors in the plaque themselves. If you would want to do that, which is maybe a smart way of making stents smarter than they are, you could imagine that there is a sensor for flow, for instance, on the stent. There is actually people who try to do that, to try to identify whether the blood that's flowing through the vessel is decreasing because of clot formation, for instance. make stents smarter. But of course, that is invasive. That requires indication for the stent implant in the first place. Did this address your question more or less? Yeah, thank you.
So,
how much of a factor does genetics play into this, and how is that figuring into your research?
Yeah, at this point, it's not really included. Atrial thrombosis is not a monogenetic disease, so it is considered as one of the risk factors without having been really identified, I think, specific mutations or whatever. For instance, for heart attacks, it's very clear that if in the family, a close family, there is someone who had an heart attack at a very young age, before 45, that is a very significant risk factor to include in the factors that you account for to identify the population at risk. You see, what I'm trying to do cannot apply to the overall population. It's a pyramid, and we have to be able to identify those that are at the highest risk among the high-risk patients. And family history of an MI at an early age is a very strong risk factor. Thank you.